Hello there, my name is Mirza Lalani. I'm an assistant professor at the London School of Hygiene and Tropical Medicine, and I also work for the Quality, Safety and Outcomes Policy Research Unit. We comprise the organisations you see listed, and I'm going to present to you today a cross-unit project that we're undertaking on the management and improvement of quality in integrated care systems. I'm not going to labour too much on what integration is. I'm sure we all know by this stage. What I want to do is focus primarily on quality in the context of integration and integrated care systems. You'll know the ICSs here in England launched this month, on the 1st of this month. But integration is an organising principle and for our health and social care services. But the more recent emphasis in the development of ICSs has been on this notion of improving population health, of prevention, reducing disparities and inequalities. There is, of course, a well-known definition for quality, and quality is a multi-dimensional concept, really. Three dimensions tend to predominate in the literature and in policy, particularly for the NHS here in England, which is clinical effectiveness, patient safety, patient experience, and actually it's the most commonly used dimensions globally as well. But there are other dimensions coined actually by Maxwell a couple of decades ago that extend to aspects of population health, such as access and equity. So how does a definition for quality sit against the backdrop of integrated care? Well, we could say that ICSs are responsible for achieving the best outcomes through the provision of evidence-based services to all, so that's your effectiveness, whilst avoiding harm, there's your safety, and ensuring a positive experience of care. Now, across England, there is emerging evidence of significant variability actually in health and clinical outcomes, and that's probably been exacerbated by the COVID-19 pandemic. And quality management is seen as a critical element in addressing these disparities. So what's the aspiration for quality in integrated care systems? So about a year ago, the National Quality Board came up with 6 principles. And quality is a shared commitment, a population-focused vision. We discussed that in the previous slide. This notion of co-production, co-designing services involving local communities and people and patients and service users. Clear and transparent decision making and timely and transparent information sharing. And this principle of subsidiarity, the notion that the system will control certain aspects, they need to be applied across a wider footprint. But responsibility, delegated responsibility and accountability for quality will reside with place. So what does quality governance look like in an integrated care system? So we have plagiarized this with permission from one of our participating integrated care systems. And this is a quality governance structure that they've designed for themselves. And this is what they believe works for them locally. And it's been co-designed with input and consultation and collaboration with a number of stakeholders outside of healthcare that make up part of the system. So social care, voluntary organisations, community representatives. And they believe that this incorporates all those different perspectives of quality. But there are 2 main components, I suppose, to quality governance locally. The quality committee is part of the integrated care board, and that is essentially the successor of the assurance function that was provided by the CCG quality committees. And then, of course, you've got the system quality group, which is more of a engagement, educational improvement forum for quality at the system level. So the aim of our study was to understand how well a sample of English ICSs were able to address quality in the health and care system. We wanted to identify the key goals and priorities and emerging definitions in terms of quality represented by all those different stakeholders from across the system. We wanted to identify key barriers and enablers to implementing and developing the agenda. We were keen on providing feedback from those early findings to our participating ICSs, identifying the gaps. And then what we hope to do going forward is assess their overall progress over time in terms of achieving those quality goals. So our methodological approach comprises of two phases. Stage one, which commenced at the end of last year, and we've really just finished in the last 2 months, so we're presenting preliminary findings. We sampled 4 integrated care systems, and they varied in terms of the demography and the maturity, which was a subjective assessment in terms of their maturity for integration. It's a qualitative study. We've undertaken interviews with senior management from across the integrated care system. We've attended relevant meetings, and the senior management comprise, of course, the executive leads of the integrated care system, healthcare provider CEOs or deputy CEOs, directors of adult social care or children's services, CEOs of local voluntary charities and organisations, CEOs of Health Watch, and other individuals that represent, senior individuals that represent public patient involvement locally, as well as quality leads. And this is very much a collaborative approach. So our role is to hold up a mirror and identify issues that may be occurring in ICSs that senior management are not necessarily aware of. And also it's to encourage sharing and feedback across all 4 of our participating ICSs, which will hopefully support peer learning. So through a thematic framework approach, we came up with 5 key themes. So the first of our themes is context, and context is integral to integration and to developing an ICS and therefore a quality system. In one of our ICSs, there's an extensive history of partnership working across care boundaries. So the integrated care system was preceded by the SCP in 2017. So there was some familiarity of working across providers and places. The CCG, combined CCG formed probably about 18 months ago, so that certainly helped. There was an existing award of MCP Vanguard for one of the boroughs, and 3 of the boroughs were part of the Pioneers programme. So there was familiarity there in terms of working together. And within that same ICS, there's existing quality expertise at provider level, actually recognised and awarded in those couple of providers for their quality improvement models and quality improvement work in healthcare over the last couple of years. So those aspects are certainly enablers to developing a quality system. We also were able to identify this very interesting theme around conceptualization of quality. Now, it's unsurprising that when you ask a lot of the interviews, particularly those that represent healthcare organisations, how they describe quality, they describe it in terms of safety, effectiveness and experience. That's quite a clinical definition. But then, along with the non-health stakeholders, describe quality in terms of population health, in terms of well-being, in terms of reducing inequity, improving access and addressing inequalities. And non-health stakeholders definitely take a more person-centred view of quality compared to the service-centred perspective provided by healthcare providers. And non-health stakeholders see quality as something that goes beyond service users, but to residents and communities. For all stakeholders, the ambition for quality is not just to improve quality within their organisation, but to build it into care pathways and think about how quality can be assured and improved in those transitions of care, in those gaps between providers. However, the awareness of quality does vary across the system. And this was evident in a number of the interviews we did with, I suppose, particularly healthcare leaders who, when we asked them about quality, talked about standards and safety and so on, but also talked about performance and KPIs and assurance. And then themselves actually acknowledged that, well, if you undertook the same interview and asked the same question to frontline staff and those at the service delivery level, they would talk probably about quality improvement, about what good quality care looks like to them and to service users, and this notion of personalisation. And they acknowledge that that's a definition of quality that they need to incorporate into their way of thinking. So how are quality systems developing? Well, we identified 5 key components of the development of these quality systems. Culture is very much about moving away from this model of assurance, risk aversion, and a reactive model to improvement, to risk-taking, to learning, sharing, prevention, collaboration around interdependencies. And interestingly, anyone who's done any research with local authorities, social care workers, will know that that is how they view their care. They're very much about promoting independence and thinking about the person, but also sharing issues and good practice, etc. People are key. You know, those who lead a system in place, quality leaders, those who have been in place longer, who will go from being quality leads in CCGs to being appointed to do the same role in an ICS, that have been around the system longer, that have formed those relationships with colleagues across care boundaries, seem to be able to engage colleagues across the system much more easily. Priority setting, this tension between top down and bottom up. Who should dictate what the priorities are? So one ICS has taken the approach of, what are the key priorities at the place level? What are we interested in a system? How can we marry the two together? Others have said, no, we're going to impose priorities at a system level, which kind of clashes with this notion of subsidiarity. Quality governance, structures at place and system. We've talked, I presented that schematic earlier. Quite assurance focused at this stage, but acknowledgement that intelligence will be needed on risk and good practice flow. And even with measurement, rebalancing across performance and organisation-centric, disease-focused measures towards more person-centred outcomes. So what are the challenges that hinder the development of quality systems? So there are generic challenges that affect integration, not surprisingly also will affect development of quality. But one that was mentioned frequently was the COVID recovery, the backlogs and the impacts on staff, their retention, and of course the workforce shortages mean that recruitment is challenging. There's lack of clarity around the understanding of roles of providers, of the neighbourhood, of place and system in terms of population health and addressing inequalities. Relationships. So prior to the pandemic, local authorities and hospitals, for example, didn't always work that closely together, but the pandemic resulted in local authorities coming together with healthcare providers, coalescing around common problems. And those relationships that have been formed as a result of the pandemic must be capitalised upon by the wider system to support integration. In terms of specific issues for quality development, mechanisms for public involvement, systems are grappling with their best strategy. What's the best approach to engaging members of the public? How do we frame co-production? There's a danger that it's sometimes conflated with experience and participation. And there's an over-reliance that somehow Healthwatch and perhaps a local authority will be the key drivers for co-production. So how are integrated care systems mitigating against the challenges that we've identified? Well, they're building on good practice that already exists in partner organisations. They're looking at their elective lists with a population health approach lens and assessing it based on inequalities, on need and unmet need. At least that's the suggestion from one ICS. Continuity of leadership is key, recruiting senior roles from within the system. And often highlighted was the shared care record, which of course supports integration through information sharing and sharing of data. But in most systems, this doesn't really exist at a system level as such, more at place. So there's certainly some further work that's required to be done there. So our early conclusions are that there's lots of aspiration on population health and reducing inequalities, but in the short term, funding and resources will be allocated to elective recovery. And so therefore, against this backdrop, it will be much more simple for ICBs to adopt an assurance model, which in turn hampers attempts to improve quality. Promising rhetoric evident in early strategies for co-production, but actually genuine people and community involvement cannot rely exclusively on local authorities and Healthwatch. The NHS approach needs to leverage local expertise and assets. And much of the substantive quality work undertaken within a system is actually a place level. So ICSs need to be able to develop mechanisms to capitalize on local quality approaches, ensuring that some of that good practice is disseminated across the system. And that trade-off between system priorities and system goals and place priorities and goals will need to be met, and that is a significant. Just wanted to acknowledge the contributions of the entire research team and our PPI colleagues who have provided a unique and informative perspective on the data, and of course the study participants who, despite the constraints that they're under, were willing to speak to us. And if you want to know more about the project, please go to our programme website and do feel free to get in touch with me should you have any more questions about our work.